last session before lunch. That's going to be a panel discussion. Management of advanced renal cell carcinoma. May I request Dr. Ashit Ranjan Dev sir and Dr. Taposh Maji sir to please join us on the stage and introduce the moderator and the panelist. So this session is sponsored by ADMAC Oncology, and apart from the panelists already planned, may I request Dr. Shombit Mohanty, molecular pathologist, to join us on the dais as a panelist as well.
Okay, so I invite Dr. Shaurabh Misra as a moderator to come into the dais. Please start the session.
So I would request my panelists to please come on the dais. We have Dr. Kaniska Sarkar, Dr. Abhijit Das, Dr. Abha Kumari, Dr. Anupam, Dr. Chandrani, Dr. Rakesh, Avinash, Debopriya Mandal, and Dr. Atanu.
So Dr. Shombit Mohanty is also joining.
Yeah, Dr. Sambit will definitely have him. So let us start with just a general discussion. I'm not going for any case-based discussion. So any metastatic RCC patient which comes to your clinic, now we treat all these patients with whatever modalities we have. So how do you choose which factors you take into consideration while treating a patient with metastatic RCC? All the panelists can take it. I can start with Dr. Rakesh.
Yeah, very good afternoon to all of you, and thank you for inviting me for this panel. So of course we'll have to see whether this is an upfront metastatic patient or the patient has accidentally stepped into the chamber of the medical oncologist with a report that this is a RCC, because sometimes we do get these patients, but that is relatively rare. So if the patient has come to us with upfront metastasis, that's a different ball game. If the patient underwent a treatment for RCC long time back, and now the patient has come with metachronous disease, then that's a different ball game. So we'll have to assess the patients on the basis of the history of surgery, and then we have number of parameters to select our best treatment option. Okay. MDT would be very useful.
Okay. So next, please.
Yeah, I completely agree with Rakesh sir. So basically, what treatment the patient has received prior. If the patient was an upfront case of an RCC and has progressed, that is one important, because that will eventually lead us to do the prognostic assessment of IMDC. So we usually follow in our setup the IMDC stratification index. Yes, disease burden is of course very, very important, because based on the disease burden, we need to see whether, the urologist has a place in, in this case in cytoreduction. Then prior therapy has already been discussed, of course.
Okay. So yeah, madam, you can take it up also. When you have a metastatic RCC patients, how do you choose your therapy? Which factors you take into consideration?
If it is a metastatic disease and patient is asymptomatic.
Could you be louder? We are not able to hear you.
If it is a patient is a metastatic disease, if it come to us, first we will do the metastatic workup, and we will see what is the symptom. And according to that, we will do the further investigation like the biopsy and histology and patient performance status and all that. And based on symptom, we will decide the further treatment.
Okay. So as our panelists agree, these are the bare minimum things which we see in our clinical practice in making a decision. We see the histology, clear cell versus non-clear cell, that has an impact on therapy. Most of the studies have been done on clear cell RCC, and so data is also maximum on this. Non-clear cell, we have upcoming data. Now, Dr. Sambit, when we see this sarcomatoid or rhabdoid component, we are worried as clinicians. We find that these patients are mostly into the IMDC poor or intermediate risk. That means bad biology. So how do you define this sarcomatoid and rhabdoid component in your patient? On your samples.
And as you said, mostly the studies are on the clear cells. So for us, like for pathologists, we have to tell you guys like what is a pure clear cell or it is a non-clear cell histology, like eosinophilic or anything. In addition, what is the percentage of the tumor has sarcomatoid dedifferentiation?
So you can tell that on the biopsy, true cut
Biopsy, we should give a rough percentage at least, like maximum of focal, and any rhabdoid is bad.
Okay. So the rhabdoid component, sarcomatoid component, they can be part of the clear cell or part of the non-clear cell?
Mostly they are seen in the clear cells.
Okay.
In the non-clear cells, they are rare.
They're rare. Okay. And when we see a sarcomatoid pathology, so probably that's a high-risk biology disease.
One is sarcomatid and what type of sarcoma. There are two things we have to tell, like what type of sarcoma it is differentiating into and whether it is there or not.
Perfect. So now, once we have the histology and everything with us, so I'd like to ask our medical oncologist friend. So all of we go for risk stratification, right? IMDC risk stratification. So it's a simple thing to do. So what do you think is the problem with this? Are you all absolutely this the perfect stratification, or do you think something else? So I can just tell you one example. Now, if I have none of these points with a patient, suppose a patient was operated 2-3 years back, now he is very, very symptomatic with lot of lung metastasis. He's symptomatic. But none of these criteria, I mean the parameters are there, so he's a favorable risk. Do you think he's the same biology as absolutely asymptomatic patient? So one of the problems with IMDC risk is that we do not take the disease burden into consideration. Now how do you think about, what do you think are the fallacies with the IMDC? Madam, you can take it. Rakesh sir, you can take it.
Yeah, so the one which we used to follow before was the MSKCC criteria.
Okay. Interleukin
It was
era.
yes, so that was during the time of interleukins and interferons. And there was one criteria which was the LDH level. Now the LDH level was replaced by the upper level of neutrophils and platelets in the IMDC criteria. And this IMDC or Heng's criteria was introduced when patients started getting more and more tyrosine kinase inhibitors and not interferons. Now, kidney being immunogenic, there is a lot of cytokine release. And the moment you have a huge amount of cytokine release from a bulky tumor, you normally initiate an inflammatory response. And because of that inflammatory response, there is a reactionary rise in neutrophils. So you can back calculate and say that maybe this person is having a very bulky disease. The upper level of platelet is something which is quite dubious. Any cancer patient, 4 days back, if the hemoglobin level is 11, might be suddenly lying in about 3-4 days' time, without the patient realizing well that the patient has lost a lot of blood in the urine. And if you look at the calcium levels, you need an albumin correction also. Okay. And a lot of patients will be less fed, cachectic, albumin levels are different, and you may not get the exact value of calcium. So if you see these kind of patients on and off, you will come to realize that there are certain patients who, as a clinician, you can judge these patients are actually poor risk. And of course the parameters are there. Most of the patients will not get a surgery done initially. So 1 point is always there most of the time.
Perfect. So what he means to say is that although IMDC has been universally used, now even with immunotherapy, we have data that the IMDC risk stratifies into 3 categories with 3 different outcomes. Still, it is not the absolute risk stratification. We have also to consider the patient's the disease burden, the symptomatic, how symptomatic is the patient. One more important thing is that what he was saying is that all the other parameters other than the time from diagnosis could be affected by other parameters, not disease per se. So when we take into consideration all of these things, we have to plan the treatment. Now MSKCC was used previously. So if you compare the MSKCC and IMDC, in 77% of the patients, in the same patient, if you apply MSKCC and IMDC, 75% of the patient will have an agreement, 22% will be upgraded, and 2 will be downgraded. And this is what I was telling, that even though IMDC was predominantly in the TKI era, we have also data to show that it can be utilized in the patients who are on ipilimumab and nivolumab and IO-VEGF. So that can also be, IMDC can also be used in this pathway. Now we come to the urologist. Cytoreductive nephrectomy was routinely done. Just tell us what is your thought on the cytoreductive nephrectomy, which are the ideal patients for that. Urologists, we have, no one is there? So do we have anyone from urology in the audience? No one. Okay, so we'll quickly go then. So what does the medical oncologist think? Cytoreductive nephrectomy, when do you choose?
Only in the favorable response. I don't think the intermediate and the good response have got any advantage of cytoreductive surgery.
Okay, so Carmina study showed that sunitinib alone versus surgery, cytoreductive nephrectomy with sunitinib. Sunitinib alone is not inferior. That is what we knew. Now coming to even in those patients, suppose whom do you want to choose, as he very clearly said, probably in the very favorable risk subset of patients, or even if it is intermediate risk, only one risk factor with a very limited burden of disease probably would be considered ideal for a cytoreductive nephrectomy. All other patients go for upfront systemic therapy. This is what we have learned from. There is also a possibility for delayed nephrectomy. The Surtime study, it showed in some of the patients, if you can go for some systemic therapy upfront, and then when you have a good biology, disease control, and then you can time your nephrectomy rather than upfront nephrectomy, some of these patients would have an improvement in outcome. So like that, we have to choose for cytoreductive nephrectomy. So this is what I told exactly. Now we will come to the next scenario, to our radiation oncology, SABR. Previously we thought these are radio-resistant tumors. A lot of work has been done, is being done. Please tell us who are the ideal patients whom we should be sending to you to consider SABR in metastatic RCC. Also whether you would like to go for SABR to the primary or primary and metastatic sites. Please tell us.
Conventionally, renal cell carcinomas are not sensitive to conventional dose fractionations. But we can see that these cancers can respond to higher doses per fractions as uses in SBRT. So if we have an oligometastatic disease, probably with one or two meds, then I think it's a very good modality.
So
to
oligo
use
you would be defining as what actually for you?
Probably to
So
two
less
to
than
three
3,
sites.
up to 3 max?
Up to 2 to
So
3
the
sites.
Astro has given a definition of oligometastasis. They say that for renal cell carcinoma, less than 5 sites of involvement should
I
be
think
qualifying
prostate
for.
also same thing,
Yeah.
less than equal to 5. Yeah, please. So you go for a higher dose, that's what you are telling. Okay.
So I think SBRT can be considered in these cases.
So to the
definitely.
primary or to the metastasis or everything?
SBRT to multiple sites will be
Okay,
difficult.
so this is one study where we were seeing that here they have given stereotactic radiotherapy with a short course of pembrolizumab. So if you can think this is to be utilized in our practice, so some of these, so all these patients had received 1 or 2 prior lines of systemic therapy. Still they had 1 to 5 oligometastasis. So what they did was that they went for a single fraction SABR to the primary and also to all the metastatic sites. That is what this study did. And they could see that there was a very good local control. It was feasible to combine SABR along with systemic therapy. So there is definitely a case for SABR along with systemic therapy. We should not deter the patients that no, this is only a systemic disease. Local control is very important. So we should discuss this in the multidisciplinary tumor board as well. Now we come to the systemic therapy. So our medical oncology friends can tell us, we are now having lot of options. IO, TKIs, doublet. We also have triplets, ipilimumab, nivolumab with cabozantinib. How do you choose your patients?
So sort of triplet, the cosmic trial,
Yeah.
it's a new trial actually. They took 3 agents, Nipo, EP along with TKI. Now before we go on to the results of a triplet, we have to understand that if the 2 IOs have slightly different toxicity profile, ipilimumab has a different toxicity profile, a lot of colitis happens, a lot of GI nuisance, and then you have the other one, the Nivo, which has a separate spectrum of toxicity. On top of that, you have a tyrosine kinase inhibitor. So when certain toxicities overlap, it is very difficult to find out the offending agent. So a triplet will always be a challenge. And if you give triplet at the beginning, how do you sequence? You
Perfect.
don't have any drugs left. You do not know what to do. So we'll wait for the further data and the updates of the cosmic study. By and large, the combination of TKI with immunotherapy is advocated in all risk factors. By and large, if you see pembro with lenvatinib, you see nivo with cabozantinib or axitinib with pembrolizumab, I mean, pembrolizumab, you have indications for good risk, intermediate risk, favorable and high risk, but there are certain indolent cases, very slow growing tumors, very oligometastatic disease, where it won't be bad if you choose a single agent tyrosine kinase inhibitor and wait for combinations in the later phase.
Madam, you can take it up. So how do you go for, you have a lot of options now. So VEGF plus TKI. So in which patients you will use only VEGF TKI? In which?
Actually, I am radiation
is it?
oncologist, so I can't.
Okay. So any other medical oncology? Yeah.
I'm also
please,
radiation
please.
oncologist, but I'll
So
take
please
that
tell us.
question.
We'd like to listen to you.
So the idea is, for us on a very practical setting, it all ends up to the affordability of the patient. That is number one.
Logistics.
Okay. Number two is, if the patient is affordable, then we need to make them understand, like, this is what your risk stratification is, and this is what you
so risk
qualify
stratification
for.
and what?
Yes, this is what you qualify for. Now, if that patient is affordable and going ahead, then we go ahead with the cosmic regimen, number one. But if the patient is not affordable for chemo IO, as Dr. Rakesh has said, you can always choose between any of the TKIs that at present, which are present with us, that is eventually give you some benefit rather than no benefit.
Okay. So basically, favorable risk disease is predominantly driven by the VEGF pathway. That is why in most of the favorable risk patients, single agent VEGF TKI is good enough, if of course it has an indolent biology. And then we discussed, if it is an oligometastatic disease, we should consider the local therapies as well. So probably majority of the patients, but then how many patients do you actually get your clinic who are favorable risk? Very few, because anyways most of them are newly diagnosed. So most of the patients will land up into intermediate or poor risk category, and in this subset of patients we have to go for doublet predominantly, because triplet, as was discussed, although there is an improvement in outcome in comparison to doublet, it's a toxic regimen. And if you give everything upfront, what are you going to do when the patient progresses? Now, in the triplet, in the intermediate and poor risk also, ipilimumab, nivolumab has a very, very long follow-up, longest follow-up. And in the poor risk subset of patients who want no toxicities from TKIs and who want a treatment-free interval, this is a limited duration treatment. Otherwise, TKIs have to be given lifelong. In those subset of patients, and also in sarcomatoid and rhabdoid histology, probably nivolumab plus ipilimumab is going to score over the VEGF TKIs and the IOs. And then in the other subset of patients, whether it is an asymptomatic or symptomatic disease with intermediate and poor risk patient, nivo plus cabozantinib, lenvatinib, pembrolizumab, exitinib are decent options. Now, Dr. Sambit, non-clear cell RCC. Now, these subset of patients, you have worked a lot on RCCs, and you have, and along with your group, you also got a new entity, I think. Could you please elaborate on that?
First, in the last WHO, I was involved in the renal chapters, with a bunch of other people. So papillary, I'll just go over in nutshell, like papillary, we do not grade papillaries now to type 1, type 2, we are not doing it, we are not classifying it further, because type 1 is a prototype papillary. Anything which looks like type 2, they should be further classified molecularly, like we have FH deficient, SDH and other ALK rearranged RCCs and all. That is one. And number two is, I have seen people grading chromophobes. Chromophobes should not be graded. They look bad, but they do not behave that badly. That is one. And we are trying to give a name to the RCC NOS, or the unclassified category, to a specific name.
Okay.
So that is the basic thing that current WHO has. And we have a new entity of mTOR pathway altered or mutated RCCs, which are basically pink tumors. So not much of follow-up in those tumors.
So basically, papillary RCC would be the most common non-clear cell RCC, which we see in our clinic, and then there are others also. You see single agent TKI is very limited response, 5 to 20%, median PFS 6 months. Now we have a phase 2 data. from pembrolizumab plus lenvatinib, which in fact has the maximum response in clear cell. We see here that response is not bad. In clear cell, we have 75% response rate, and here we have a response rate of almost 50%, which is very good. And the median PFS is around 18 months. So something we now have for us in the patients who would otherwise not go for anything. So in non-clear cell, we can benefit them from pembrolizumab plus lenvatinib. I think we have come to the end of our discussion. I would summarize, IMDC risk stratification is relevant in real-world scenario for decision-making in treatment of RCC. However, clinical judgment is crucial. Cytoreductive nephrectomy might be beneficial for patients with only one IMDC risk factor, especially if they have only one metastatic site or very limited burden of disease. SABR is feasible in oligometastatic RCC with excellent local control. You can also go for SABR to the metastatic site, and you can combine with immunotherapy as well. Systemic therapy with VEGF TKIs is appropriate for good risk patients. Systemic therapy with doublet IO TKI combinations are appropriate for intermediate poor risk patients and aggressive biology good risk patient. Triplet therapy is feasible but toxic. Pembrolizumab plus lenvatinib is preferred in non-clear cell RCC. Nivolumab plus EP is preferred in sarcomatoid and rhabdoid histology. So I would end with this very, very positive note. The median OS of patients with metastatic RCC in the intention to the CheckMate 214, that is the EV plus Nivo, has now reached 53 months. This was beyond imagination a decade ago. So we are doing a lot of stride, we are making a lot of stride, and we should be doing. So final comments from the panelists or the audience or the questions. Thank you. Thanks for the invitation.
Thanks to all the panelists and Dr. Shourab for your excellent conduction
Thank you,
and for this very informative discussion.
Thanks.
So
Thank you.
I have a small comment. Sorry.
Yeah, please.
So I'm a surgical uro-oncologist.
Yes.
So basically, we used to have the dictum that if you're going to do a cytoreductive, the burden of the disease should be more than 75% in the kidney and less than 25% being outside the kidney. That's this thing. And the second thing I would like to say is that it should be locally resectable without any damage to because you can't do more damage than what, because they are going to require adjuvant and you can't delay that as well. So that's one point I want to make. And one small query is that what is your experience with the collecting duct cancer? I know it's a very rare kind of disease we come across, but what would be your first line in a metastatic collecting duct? I know that it's non-clear cell it's a huge spectrum of disease. I don't know whether you can club it together. Any specific?
So basically, I don't remember. I think there was one patient I expired. I don't remember. But then this Pembro plus lenvatinib, it worked irrespective of the non-clear cell histology, except in the chromophobe. In all other subsets, the response rate was 50% more than that. So I think collecting duct also, we can go for this regimen.
Thank you, Dr. Shourab Misra, for the excellent moderation, and thank you our panelists for joining. Before we break for the lunch, may I request our chairperson, sir, to hand over a memento to Dr. Shourab Misra as a token of appreciation. I request the panelists to join for a photo shoot. Please, the panelists, please join us for a photo shoot. This session was sponsored by ADMAC Oncology. Thank you, ADMAC Oncology, for sponsoring this session.